We will try to cut this a little bit shorter, just for the interest of time. So the purpose of this talk really is to show two things. One is to show the integrated model of sort of pre-hospital area utilization and sort of interfacility area utilization within our system. And it serves as a little bit of a preamble to your tour that you're going to do in the afternoon. So to give you some context of sort of what to look for when you're upstairs in PCCP later. So without further ado, the purpose of this is also to show you just the patient journey. So from scene all the way through to hospital, then through interfacility transfer. We have a video that we'll show you later that will give you an idea of what to expect. What I'm going to do, so this is a video you'll see later, and Don's going to talk a little bit more about this. But what I'm going to do quickly is just talk about pre-hospital air resource utilization. And so there's three main programs that we have within BCEHS right now. The first is auto launch, the second is early fixed wing launch, and the third is scene requests. So just to talk a little bit about auto launch is a dispatch-initiated protocol in which a dedicated helicopter and critical care team crew are dispatched based on MPDS codes. So, and the purpose of auto launch is to try to get critical care to the patient or to the sick trauma patient at the scene, as well as improve our transport times. So there's two different criteria to meet auto launch. The first is the 911 call. So a bystander or anybody calling out 911 will go through to dispatch, and dispatch will code it accordingly using MPDS. So that's the first criteria. If they meet the MPDS auto launch codes, which we have predetermined, the helicopter gets automatically launched. At the same time, a crew on the ground is dispatched to the scene. And so at any point, so the helicopter will continue to the scene until one of two things. So one, when the crew gets to the scene, they confirm that there's continuance criteria, which I'll talk about in a second. Or if the crew can't actually get to the patient within a reasonable time window, the helicopter will continue going to the scene. The crew can cancel, or the auto launch can be canceled based on one of two things. They don't meet criteria 2, or there's another alternative explanation. Auto launch only also applies to patients where the transport time by ground to the destination hospital is more than 30 minutes. So this is what I talked about cancellation. So if the call circumstances, so let's say the 911 call person calls back and says, oh, actually, you know what, that's not exactly what happened, the circumstances didn't change, then the auto launch can be canceled. If the crew that arrives to the patient also realizes that the merits of the initial call aren't true, then they can also cancel as well. Once the crew arrives, they usually have to call our paramedic support or paramedic specialists, which are the clinical consultation there to confirm that the scene response by the helicopter and the CT2 crew aren't required. So these are the, there's 2 pages of these. This is the first page of MPDS codes that we've decided are for automatic helicopter launch. So you can sort of see burns, hazmat, drownings, electrocutions, and significant falls, as well as inaccessible, so entrapments, difficult extrications, penetrating trauma, high-risk MPAs, and other traumatic injuries, so patients who are in arrest unconscious or chest or neck injuries. So these are the auto launch codes themselves. The continuance criteria are based on the major trauma definition. So if a patient meets physiological, anatomical, or mechanism criteria, then the helicopters continue. Access, as we talked about before, is one, either the crew can't reach the patient in time, or even if they do, they identify major injury, but they're not able to get the patient out. The second pre-hospital air resource utilization is through the early fixed wing launch program. Now this is a little bit different. The purpose of this is to improve transfer times for trauma patients throughout the province. So this is also based on major trauma criteria, so for both physiological, anatomical, and mechanism indicators, but they're not initiated by dispatch. They're initiated by paramedics at the physical trauma scene. And so for these patients, they're usually outside of the auto launch window or the area. So paramedics at scene will call to dispatch, so specifically to the paramedic specialist, and they will link in our EPOS physicians as needed to request an early fixed-wing launch. So the fixed-wing then gets launched to the nearest airport so that the asset is already on the way while the patient's being transported to the hospital. So as you can see, the criteria for early fixed-wing launch, again, is consistent with the major trauma criteria. The last is scene requests. So these are patients who don't meet any of the auto-launch criteria, but they meet a significant sort of mechanism of injury. And so there are two parts to this. There is helicopter staging and helicopter launching. So if an event meets a specific mechanism of injury, the helicopter is staged. And then if they meet either a specific mechanism of injury that we've pre-identified, which are currently under review right now, to sort of figure out whether or not helicopters should be launched based on mechanism rather than just staged, or if they meet continuation criteria, they're launched. So the staging is that the crew and the pilots are notified of a potential launch, but they haven't actually started the engine of the helicopter yet. So these are the mechanisms of injury for staging. And specifically, there's 4 mechanisms of injury where they'll be launched for. So again, these are all still consistent with the major trauma criteria. So again, if they meet physiological criteria and anatomical criteria, the helicopter will be launched. So the reason for this program is because there's still certain traumatic events that still require careful consideration, even though they don't meet the auto-launch criteria, right? So, specifically if the response area is outside of what we normally expect the helicopters are able to go, or there's specific circumstances, so either access to patients difficult or access to trauma at what the expected receiving hospital is different, there's reasons for this to exist. And so when a crew requests for a scene request, it usually is in discussion with either the dispatch supervisor, the critical care crew itself, or the manager on call. And it can be usually a dialogue amongst everybody. So moving forward, we've talked a lot about trauma in terms of pre-hospital area resource utilization. There's a lot of talk within our system, especially from other groups, of utilizing our resources in the pre-hospital setting. So hot stroke is the seemingly most hot topic right now, especially with the introduction of UVT. And so are hot strokes eligible for air resource transport? We have some difficult geography here, even close to the lower mainland. There are patients on islands that are difficult extrications off the island to a stroke center. So there's some thought whether or not it's good or an effective use of resources to transport these patients by air, primarily, even before their CT scan to the stroke center. So these are things that are currently in discussion. And same thing with STEMI. So in isolated areas where patients don't have access to either thrombolysis or PCI, is this a valuable discussion to have in regards to using air resources to access these patients? So that's enough about the pre-hospital section. I'm going to leave it to Don to talk about the inter-facility transport side.
Perfect, I'll just jump into this. All right, so inter-facility transfer. So I oversee what we call patient transfer services. Patient transfer services is 2 communication centers. It's the patient transfer network, which we're going to talk about next, and the patient transfer coordination center, our air ambulance dispatch. So we're first going to talk about PTN, Patient Transfer Network. This is the planning of all transfers throughout our province. And you're going to hear a lot about collaboration and partnerships. So over the last few years, we have been working very, very closely with the health authorities as one team. So we have a receiving hospital, receiving health authority, sending hospital, sending health authority, and ourselves. There's always 3 people in every transfer. So we're going to talk about what PTN does. It's going to be easy just to show a quick video of the process from a 911 call coming in to a patient being moved to their local hospital, and then PTN needing to be involved moving this patient to a tertiary care center. So we'll quickly watch the video, and then that'll help explain PTN and your tour later on today.
Okay, tell me exactly what happened.
So now the patient gets to the local hospital and PTN gets involved in the transfer.
Patient transfer number. This is Chelsea. Is your patient's life, limb, or organ imminently threatened? Yes, sir. Okay, may I please have your patient's PHN? It is 9321564632. Okay. Turn your patient's last name. Smith, S-M-I-T-H. First name? Jason. Date of birth, please. October 10th, 1958. Okay, and where are you calling from? Campbell River. Okay. And who's the sending physician, please? It's myself, Dr. Ashton. ASHTUN? Yep, perfect. I'll just get a case open here, Dr. Ashton. While we're on the line, is this condition the result of a trauma? No, it's not. Okay, is your patient currently intubated or vented? No, they're not. Does your patient have any known infectious precautions or dialysis needs? No. And where's the patient in Campbell River Hospital? They're in the emerge. Okay. Okay, may I please have your patient's diagnosis? It's a STEMI. Okay. Okay, Dr. Ashton, let me bring on my critical care paramedic and then I'll bring on the interventional cardiologist from Victoria, okay? Thank you. Thank you. One moment.
Yes, Baptist Ross.
Oh, hi, Ross. It's Chelsea, PTN.
Hi.
Good morning. I've got Dr. Ashton on the line from Campbell River, hoping to rendezvous LLTO transfer, please.
Okay.
Sounds like it's a STEMI.
Okay, thank you.
Just want to bring on the interventional cardiologist from Utilization Hospital.
Great.
Thank you. One moment.
Can we do a weather check? Campbell River to Victoria, please. Copy.
Ellie Debris speaking.
Oh, hello, Bree. Could you check the weather for trips Campbell River to Victoria, please?
Sure, I can check the weather and I'll give you a call right back.
Well, Julie, switchboard. Oh, hi, it's Chelsea with PTN. Hi, just wondering who your interventional cardiologist is. Dr. Jones. Thank you. It's Dr. Jones today? Okay, and this number for Dr. Jones, please? It's 250-660-1524. Perfect, thank you very much. Thank you. Bye. Bye.
Hi, Jordan, it's Bree and Helijet. Cooper just called me about Campbell River to Victoria. Go ahead with the details. Okay, sounds good. We'll just give the crew a brief, get some fuel, and then we'll give you a call in the air on our way to the airport in Campbell River.
Hello, this is Dr. Jones. Oh, good morning, Dr. Jones. This is Chelsea with the Patient Transfer Network. Oh, hi. Hi, I've got Dr. Ashton calling in from Campbell River, hoping to discuss a new LLTO transfer with you to STEMI. Oh, okay, great. Perfect. I'll connect you now. One moment. Hi, Dr. Ashton. Thank you so much for holding. I've got my critical care paramedic Ross on the line, in addition to the cardiac physician, Dr. Jones. Thank you.
Okay, thank you, sir.
Hi.
Morning, doctor.
Good morning. Good morning, Dr. Jones. Hi, good morning. Good morning. So I have a 60-year-old gentleman who has been with my ambulance today. We're going to keep him in CR about the 10 cycles with her spontaneous circulation. She's an inferior STEMI. We've done a few just over the 90 minutes ago, and it's failed to work. Okay. Do you have a current set of vitals or any other concerns? Well, he has a new onset of atrial fib. He's on the Trumbull, and there's no anticoagulants. His heart rate's about 160 when he came in. We gave him some beta blockers. He's now down to about 120. His BP was a little bit high, 160 over 90, and it's now come down to about 137 over 82. But he is starting fine. Okay, we'll take him. We'll bring him directly to the cath lab. Do you know when he's going to arrive? I'm not quite sure.
Hi, you have ambulance here. Yeah, we have checked the weather, and the weather is improved. So our flight time will probably be airborne out of Vancouver in approximately 15 to 20 minutes. Flight time up to Campbell River, I would put us in there around 12:15 to the Campbell River Airport.
Okay, great. And just to confirm everybody, we're going to run this transfer as an LLTO right to the cath lab? Yes.
That's correct.
Perfect. I'll send the ticket in right away. Thank you. Thank you very much.
So those are the steps of what happens during an interfacility transfer, logging and booking the call through PTN. A couple things that are important to note in that is the triaging aspect. We use the sending, receiving, and BCEHS to help triage that call. So 3 parties there, and you saw Chelsea at the end confirming that we're running this as an LLTO. This is a chance where the receiving physician can say that we want to run this as a higher level of care, and it goes through other steps. We talked about, Orange just talked about 2 different bundles, very similar to that, whether it's a higher level of care or it's an LLTO. So the other part, we're going to just walk through the quick steps of the PTN. Sending facility calls PTN. We bring on a representative of the line. Now again, if they've chosen LLTO, just on the phone queue, it says if you're calling PTN and you're calling about an LLTO, hit 1. When they hit 1, they get either a critical care paramedic or an emergency transport physician from BCEHS brought on the line as our representative. If it's a higher level of care, we'll bring on a critical triage nurse from PTN as well. Then we contact the receiving specialist and we facilitate a conference. So how we do that? The health authorities across our province, we have 5 of them, 5 major health authorities, Northern Health, Interior, Fraser Health, Coastal, and Vancouver Island Health Authority, as well as a couple independent. We have First Nations Health Authority, and we have some smaller independent health authorities. So the collaboration that we talked about is very key to this. We have 5 different sets of rules that we're following, 5 different non-refusal policies or LLTO non-refusal policies. We have a lot of our patients that are moving from Northern Health to Coastal Health. A lot of them cross health authority boundaries. So this is where the collaboration is really coming to fruition. We're seeing a lot of work done within the health authorities. And the first one is the referral pattern. So Chelsea on the video connected Campbell River to Victoria. In between there's about 5 different hospitals. But what she did is she went right to the right hospital based on what we call a health authority referral pattern. The health authorities already have pre-laid out where their patients should go. So if they have a cardiac patient in this hospital, where would we connect them to? If they have a trauma patient in this hospital, where would we connect them to? So we're not finding beds for patients across the province. We're following a very set referral pattern. So we also know that's that hospital based on the services. So this is a services spreadsheet. The hospitals have told us these are all the services we have in each hospital. So Chelsea knew that they're in between all those hospitals in Comox, Nanaimo, all the way down. They didn't have a cardiology, and that's why she went right to Royal Jubilee. We do have some challenges with this. So this is, again, another example. We have sometimes we still have physicians that are conferencing outside of PTN. They'll phone another hospital directly, and they'll have this same conference without their third partner brought to the line. And then they'll phone PTN to book the ambulance after the fact. And one of the things that we see happening right now is they're asking us to go to a hospital that's not in their referral pattern. So JKL, you can see on this one, is phoning about a patient with burns. We can see that DEF, which is not in their referral pattern, has burns as a service there. We can also see that XYZ, which is in their referral pattern, has burns. So one of the challenges that we're working on with the health authority is to making sure that the physicians are going through PTN. So we're dealing with all of the overcapacity issues, flow throughout the entire province. So of course, after we connect the receiving, we then have to request the hospital. So on most, as I say, health authorities have a non-refusal policy for LLTOs. They will accept them. They usually, if they don't have a bed, they'll go straight to their emerge, straight to the cath lab, wherever they need to go. On the higher level of cares, there's challenges that we have. On higher level cares, we phone the hospitals and make sure that there's a bed for this patient. Sometimes the physicians give us a 12, 24-hour timeline, and so that gives the hospital time to find a bed instead of sending patients directly to emerge. The challenge with that, we have a lot of patients waiting for beds across our province. We took a snapshot in September. We had 92 patients that were waiting for beds. Physicians had already had the conferences and accepted the patients, but all we now needed was beds. And I'll just show you in a moment here how that affects our air ambulance situation. Once a bed is offered, then of course the transfer is done in the PTN perspective and moved over to the air ambulance logistics perspective. So some of the challenges of the conferences outside of PTN, physicians wanting to go to facilities, not in referral patterns. Working with our partnerships in Alberta, that's a big one for our area that borders Alberta. A lot of physicians want our patients to go to Alberta. Our health authorities and Alberta may have a different idea due to, again, capacity reasons. Stable patients may be staying in BC. But again, Alberta, the physicians along that border may see it differently. So working together to make sure we're all on the same page. Waiting for beds, and even overcapacity non-refusals. We do have hospitals that do refuse, even if they're a non-refusal policy. So again, working very collaboratively with the health authorities. So the sending side of the house are what we call Patient Transfer Coordination Center. You'll see this afternoon. Both of these are in the same building. They sit side by side, the planning portion, and then of course the dispatch portion. Just a quick touch of our resources, and then I'll wrap it up here. We have 4 helicopters in our province that are dedicated. Of course, we have the ability to charter helicopters and fixed wings across our province, but we have 4 dedicated helicopters, 2 located here in Vancouver. One is in the interior in Kamloops, and one is up on the coast in Prince Rupert. We have a jet here in Vancouver, as well as a turbo in Vancouver. We have 2 turbos in Kelowna. We have 1 in Prince George, and we have 1 in Fort St. John. So 6 fixed wing and 4 helicopters. I do this presentation across the province with the health authorities as we're working together. And the first question they ask, of course, is more aircraft. 10 aircraft for a province the size of 1 million square kilometers. But what we need to look at first, and again, dealing with the health authorities, is more efficiency. So again, if we look back at that random day in September, we had 92 patients that were waiting for beds. These weren't on the ambulance side of the house. These weren't ready for dispatch. So we have average 20 to 25 transfers a day we do by our air ambulance. We'll take a plane all the way from here, go to Fort St. John, a 2-hour flight, and to pick up a higher level of care patient, and then bring them back down to Vancouver. A lot of times we'll fly there empty to pick up patients. A lot of times the health authorities have patients ready to go in that direction, but they don't have beds in those facilities. I was doing this presentation in the interior up in Prince George. They asked me the same question, why don't we have more aircraft? Our plane from Fort St. John at that time was actually flying all the way across our province to Terrace to pick up a patient to bring to Vancouver. We had 3 patients that were sitting in their hospital ready to go, but they didn't have beds. We had 1 actually going to Terrace, so that plane could have stopped in Prince George, flown that patient to Terrace. And then of course, what happens the next day is when all these patients are now finally ready to transfer, now we don't have the aircraft. So again, the health authorities are working very, very hard to try and increase capacity and work directly with us at the air ambulance side of the house to offer us these calls, whether it's going to be no refusal or how we're going to move these patients, but to really streamline the efficiency of the air ambulance. So just one thing on here that I want to touch on, because you may see it today. We're having a few glitches. We have gone live. I'm really happy to say this is about 1.5 years in the making, with an online dashboard for every healthcare employee across our province can go onto a website and log in to see where the patient's journey is in this whole process. So if you're in Fort St. John, or if you're in Prince Rupert, or you're in Kelowna, you can log on and you can see the patient's journey. You can see that they're still waiting for a conference from the physicians, or the bed's been accepted, or it's been given to the ambulance, or the ambulance is on the way, the ambulance has arrived at the sending site, and the ambulance is now finally booked away to your site, to the receiving site. So they can see that eliminates ETAs. We are just doing the testing of it now. Of course, you can imagine the privacy issues that came with this one. So 1.5 years going through our ministry and our health authorities with privacy. But we've worked it out. It's now live in our center, and as soon as it's ready to go, we'll give all the usernames and passwords to the health authorities. So I think that's it, and I look forward to seeing you in our center this afternoon.